The presenter is Dr. Kaustav Kumar Biswas. He is going to present an uppercut in echo incidentally detected RARV dilatation. Dr. Kaustav Kumar Biswas, please.
Good evening. Good evening, everybody. I begin with deepest regards to all my seniors and warm welcome to all the delegates. I'm going to share my experience over here, discussing few cases and going to learn from this august audience. The topic is an uppercut in echo, incidentally detected RARV dilatation. RA and RV are no longer the innocent bystanders of their left counterparts nowadays. And the finding of this dilated RA and RV can be quite challenging to the echocardiographer. And it's the brief recollection of the probable causes can be helpful, which can be grouped into conditions of pressure overload, volume overload, and myocardial disorders. This is just a brief recollection, the slide showing the different types of pulmonary hypertension, and of course the alveoli obstruction at different levels, and the conditions of volume overload caused by the shunts, and the myocardial disorders like ARVD, RV infarction, or Alzheimer's. I'm going straight away to the first case, where a 50-year-old gentleman presenting with cough with expectoration, shortness of breath and exertion, and one episode of massive hemoptysis, and he's got a cellulitis on right leg. These are his clinical findings, where the chest auscultation showed crepitations in bilateral infrascapular region. Chest X-ray showed opacities in the left lower lobe. The HSCT of thorax showed a cavitary lesion in the apical segment of left lower lobe with fungal ball, query fungal ball inside, which was confirmed by bronchoscopy as aspergillosis. And Doppler study showed deviation of both lower limbs. Now the echo. This is the plaques view where you can see the dilated RV and the flattened interventricular septum, the dilated right-sided chambers with impaired RV systolic function with a TAPSE of only 1.3 centimeter and AFC of 29%, and tricuspid regurgitation with a gradient of around 102, and with a non-collapsing dilated IVC of 2.3 centimeter diameter. So it was more or less like a cord pulmonally with a dilated RA&V, impaired RV systolic function with severe PH with a PSP of 117. Now, this exactly couldn't explain the fact that patient has got a lower lobe aspergillosis. It was not explained by that only. And considering that he was having a DVT, pulmonary CT angio was done, and these are the findings over there, which confirm the diagnosis of chronic pulmonary thromboembolism. In the second case, where a 20-year-old lady presented with SOBA and palpitation for 1 year, we found a grade 3/6 ejection systolic murmur in the pulmonary area. And these are her echo clips. Again, there is dilated, and we can see the RVH, flattened interventricular septum, dilated right-sided chambers, the tricuspid regurgitation with a gradient of around 143, and the turbulent jet in the pulmonary artery, which is confirming the diagnosis of valvular pulmonary stenosis with a gradient of around 128. She underwent successful balloon valvuloplasty. Straight away from the next case, in a similar case, where an elderly lady of around 52-year-old presented similar presentation and similar clinical finding of a systolic murmur in the pulmonary area. I'm straight away going to the pulmonary valve, because other clips are almost similar. And here we can see there is something very close to the pulmonary valve, just distal to it. So this was it. You can see something, some membranous structure just distal to the pulmonary artery. and this was a gradient about 91. Significant RV obstruction was there. And of course, I reported it as supravalvular pulmonary stenosis, with a supravalvular membrane causing significant obstruction. And I was foxed. Because when they took up the patient for surgery, in the OT, they found this. The valve was actually dysplastic and conical, and it was in fact a funnel-shaped valve, which gave the illusion of a supravalvular stenosis in transthoracic study. This is how it looked. Now, the fourth case is one of a 75-year-old lady. I did this in a suburban, it's in way out in outside Calcutta, and there, this lady presented with shortness of breath on exertion, palpitation, and she was hypertensive. And as I did the echo, I found this. There's the dilated right-sided chambers, and the interatrial septum bulged towards the RA, and perfectly normal RV systolic function with a TAPSE of around 2.1 centimeter, and the TR gradient of 55 approximately. Now, this lady was blessed with, a senior lady, 76-year-old, blessed with a very good subcostal window. And I got a very good bicaval view. And now we can see something. We can see the flow across the IAS near the SVC. So this was a case of sinus venosus type of ASD, SVC type. And the measurement, the defect was about 9.1 millimeter. So I was indeed lucky because their TE was not available, and she had a very good window where I could diagnose sinus venosus ASD just by transthoracic because of the good subcostal window. I'm going to the next case, where the fifth case, where a 24-year-old gentleman, he presented with increasing severity of shortness of breath on exertion, with frequent attacks of RTI in childhood and relatively free adolescent symptom-free adolescent period, with a recent increase in frequency and severity of RTI. And this was the findings. There was a grade 1 clubbing, and there was a systolic murmur in left mid-parasternal area. This is how it looked. Anteriorly there is a hypoplastic LV with a dilated RV, and now we can see both atria opening into the right ventricle, which is dilated, and also the RA, which is dilated. So both atria are opening into the RV, which is functional, and the LV is hypoplastic. Here we can see the flow, the pulmonary trunk, which is coming out from the RV, and the pulmonary flow. There's no turbulence there. This is the mitral, the atrioventricular flow, the mitral flow, in fact. And here we can see the hint of the aorta, in fact, coming just beside the pulmonary artery. It's parallel to it and coming out from the outflow chamber of the rudimentary LV, which is connected to the RV by a small VSD. And this is again the fixed, this is the TR gradient of around 87, the pulmonary flow, the mitral flow, there's an aortic flow. And there are a few still flames, just to, this is showing the VSD and the rudimentary, the hypoplastic LV, and this shows the aorta as it is coming out parallel to the pulmonary artery. So this is a very rare case of single functioning ventricle having RV morphology, both atria opening into RV, and the pulmonary trunk is arising from the right ventricle. The aorta, which is narrower, is in fact parallel, arising parallel to pulmonary artery from the outlet chamber of the hypoplastic LV, and aorta is to the left of PA. A VASD is connecting RV to the outlet chamber, and the TR gradient is around 87. And this patient was surprisingly asymptomatic when he presented to us in our MSP. So this is a case of, in fact, univentricular or double-inlet ventricle, and according to the Van Praag classification, there are 4 types, and this belongs to the second type, that is a double-inlet right ventricle. And the rule of hand is when the hypoplastic ventricle is anteriorly placed, it's always the left ventricle, and when it's posteriorly, it's the right ventricle. So in this case, we have got the hypoplastic LV with the dilated RA and RV, in fact, double inlet ventricle, and the parallel circulation. We are going to the last case, and this is really what has been a sort of uppercut. I hope to keep my jaw intact. And this is, I did it just day before yesterday when he presented to our hospital, a gentleman, 79-year-old gentleman who presented with fractured neck femur. He's hypertensive, and there is past history of permanent pacemaker implantation 10 years back. He received ATD empirically in 2012 and had pericardiocentesis in 2012 and 14. And this is his present scenario, where we can see there's a large pericardial effusion, dilated RV, and here we can see the dilated right-sided chambers with very poor RV systolic function. The TAPSE is only about 9 millimeter. And here we can see, I mean, the tricuspid valve is not closing at all. In fact, there is a free flow from RV to RA, and there is a severe low velocity TR. And this is the inflow view showing the tricuspid valve and the hint of the lid, pacemaker lid. And this is the dilated IVC, which is not collapsing at all. The LV systolic function was impaired with a paradoxical septal motion. It was about 45%. And the TAPSE was about 9 millimeter. And the mitral flow is, and the aortic flow, I mean, it showed a VTI of only 18.2. And E by E prime was again 24.8, suggesting raised LAP. This is the tricuspid flow. The TR gradient is showing only 4 millimeter and mercury, and look at his forward flow from the pulmonary valve. Negligible, and there is negligible PR as well. And we were expecting, I mean, we were looking for whether there is any fixed opening of the pulmonary valve as well, as we encounter in cases of arsenoids. But we couldn't find any. The pulmonary valve was closing fine, and there's just a trivial regurgitation, and the forward flow was this much limited. This patient, while I was doing echo, in fact, he was having a very tender epigastrium, probably due to tender hepatomegaly. And this is the measurement of the pericardial effusion from the plaques view and from the subcostal view. And he underwent pericardiocentesis yesterday. 1.5 liters of fluid was taken out, and repeat echo was done bedside, which showed mild pericardial effusion, and the RV dysfunction persisted with widely open tricuspid valve. So I leave to the elite audience and members of our special jury to guide me regarding the possible diagnosis in this case. With that, I come to the conclusion. Thank you.
Is there a previous echo in the last patient?
We didn't have. Actually, this patient came with fractured neck femur, and day before yesterday, and to our hospital. We didn't, from the medical records, we could find only this, that he underwent pericardiocentesis. We got it from the discharge certificates, and that he received ATD. And that was also empirically. We couldn't find any reports which, in fact, supported the diagnosis of tuberculosis.
But there was no TR mentioned before.
We couldn't find any other preceding echocardiography which we could compare with.
Did you have a chance to do a 3D of the tricuspid valve to see if the pacemaker lead is impinging on the septal leaflet?
Well, sir, there is a provision, but we didn't do it.
That might be one of the possibilities. Low pressure TR, right? There's a history of a pacemaker before. So if it's impinging on one of the leaflets, that can probably cause significant TR.
Could it be because of this electrode-induced damage to the tricuspid valve?
Right.
Okay,
I mean, it's worth excluding.
it's worth excluding. Yes.
Septal leaflet looks tethering.
Yeah.
Septal leaflet
Ah.
looks a tethering effects actually. So either this lead may cause problem or
So
or
it looks fixed. It looks fixed.
It looks
actually.
fixed.
Yeah.
And
That's
free
fine.
tear. So if you get a free tear and this sort of valve fixing, so something else. So there is no clinical possibility of carcinoid, no?
So it has been investigated fully yet because he came only day before yesterday, and yesterday he was, drained. The pericardial effusion was drained. So I am yet to get the full report, but probably they are thinking of excluding the carcinoid as well. But as it is, I looked very carefully at the pulmonary valve, and it was closing very fine. And from what I did one or two cases of carcinoid before, and there I found the pulmonary valve to be widely open as well. And here there was it was apposing perfectly, and the position was perfect, and with a very trivial regurgitation.
Patient is pink, no cyanosis, no?
No.
No cyanosis.
He was not even having that much of shortness of breath, but because the VTI was on the lower side, and since he is going to have surgery because of his fractured neck femur, they decided to go pericardiocentesis.
A little apical attachment of the leaflet, those tethering, so difficult to say something. So free tear, we think of it could be carcinoid.
Exactly so, sir.
Abstinence could be. But
Absolutely.
Abstinence is not relevant to your patients.
79.
79.
Yeah, ECG.
Sir, I don't have the clip over here, but the ECG actually, the ECG showed fully paced complexes. I mean, the ECG which was done in the CCU, it showed fully paced complexes.
So you can't think about the right sided cardiac.
Yes, I couldn't.
That's another problem. Then I think what should be done, at least a biopsy should be taken from the right ventricle so that you can at least think about some other causes
Like
of
ARVD.
right ventricular, like ARVD or even myocardial fibrosis and
Right, sir.
right-sided pathology.
Right, sir.
An MR with a pacemaker on.
Pacemaker.
MRI also can be done.
Yes.
With a pacemaker.
There we are limited.
With a pacemaker.
So in that case, it's a catch-22 situation.
Any possibility of an RV infarction, acute coronary syndrome possibility?
Sir, if you think of that, isolated RV infarct, that's relatively rare. But
Yeah.
and on the LV side, the dysfunction was, I think, primarily contributed by the paradoxical motion because the walls were more or less parallel to each other.
No, not really isolated. I mean, there could be an inferior wall involvement wherein you might not be able to pick it up because of the distortion of the LV geometry. So whether an RCA, proximal RCA.
Okay. So is it, in case of RV infarcts, does this dysfunction persist so long?
Yes,
Usually.
I was in the previous hospital and we had a series of around 7 patients,
Okay,
and these were all RV infarcts, and everybody had given up, and they were typical right-sided issues.
Right, sir.
And actually the surgeon was gave an option in the sense that he went ahead with just closure of the put a ring. That's all, as
Right,
simple as that. So that is another scenario, just possibility. That's all I'm thinking of.
Okay, sir.
What are his cardiac symptoms again?
No, he was asymptomatic. He was not even, that much breathless. Only, while I was doing the echo, I could make out he was just mildly breathless. He was maintaining his saturation well. And just as I told you, because he was going to have surgery, and the VTI came around 18 centimeter, and there was biventricular dysfunction. So the cardiologist thought that the intervention, the pericardiocentesis perhaps to be done before approaching any further. So the fluid was taken out.
And he had clubbing, if I remember correctly, or no?
No. That was a double-ended ventricle. Yeah.
Is the fluid a transudate or an exudate?
That is yet to be decided, sir.
Yet to be
I mean, that is, I
No,
haven't
actually-
received the report.
actually the
But
whole-
considering, sir, that there is previous history of ATD and that the patient had pericardiocentesis twice before, it looks to be exudative then.
No, there can be other causes also.
Yes.
The whole
Very
issue
true.
is this tricuspid regurg, the non-turbulent flow across the tricuspid
sir.
valve, the dilatation has not happened in a day. So
True.
it is the years which has contributed to it.
True.
So retrospectively, the previous echoes should also have shown this had you had the echocardiography series at that point of time. You did not have it. But if you construct the case retrospectively, there can be a possibility that dilatation begets dilatation. Okay? And that
Absolutely,
has led to the RV wall hypokinesia and the liver congestion leading to hypoalbuminemia can lead to multiple serous pericardial, pleural, peritoneal effusions. So what we have to do is, at this point of time, we have to rule out whether the patient is hypoalbuminemic or not.
Okay.
We have to look at the other serous cavities, whether there is collection or not. So the two pericardiocentesis tap will not necessarily point out that the patient has a tubercular etiology, because by that time, with two pericardiocentesis done and exudative tubercular fluid, we should have got signs of constriction, which is not there at all.
It is not there at all.
So it can be a retrospective consideration also.
It's kind of curious, something else is happening. So you guys see a lot more ASDs than I do, but you can get torrential flow, but your RV doesn't fail for 20, 30 years, right? So here we have RV dysfunction in addition. So there's probably something else happening. People have described tubercular myocarditis.
Sir, if I don't take it otherwise, in ASD you have a torrential flow, but the tricuspid valve is intact.
Correct. But
Here there is a clean passage of the tricuspid valve.
that's absolutely true. It's still a volume effect, right? Even free passage of TR is still a volume effect on the RV causing dilatation, and in ASD also it's a volume effect. So what I'm trying to say is the RV can sustain a lot of volume without failing, correct? And here it's failed for some reason. So there is something else happening here. Maybe a simple way.
See, is it possible that this repeated pericardial effusion, and quite a large amount, is it occurring because of the dysfunctional RV? I mean, this is dilated and
Probably.
failed. So
Probably.
it could be because of that.
Probably. So maybe since you can do an MR, maybe consider a cardiac CT.
But here
That
it's
will
spaced.
show you nicely where the leaflet is, where the valve is, and it's actually a very good test to see if the valve leaflet is impinged.
Here he was paced 10 years back, so it's unlikely that he has got a MRI compliant
Doesn't matter,
pacemaker.
but a cardiac CT will show you.
Ah,
the
cardiac
same
CT,
thing.
okay.
The only disadvantages for cardiac CT to get function,
Right.
you cannot do a prospective gating. You'll have to do a retrospective, which gives him more radiation. But he's 79, so it's fine, right?
Thank you, sir. Thank you so much. Thank you.
Regarding your regarding your congenital cases,
Right,
just
sir.
1-2 comments. He showed nicely the sinus venosus AHT, but for the students, just point, I want to mention one point. Sinus venosus AHT actually is not a AHT, that is not a interatrial communications. It is a communications gap of the sinus venosus septum between the right upper pulmonary vein and the SVC. So when you are getting a sinus venosus AHT, you should look at the right upper pulmonary vein. That is very important, because inevitably sinus venous AHT means it is a right upper pulmonary vein communicating the SVC. So that point should be addressed. And the second case, that is a univentricular heart, that was an excellent case, because this case where this is a RV type of univentricular heart, when the one aorta is arising from the smaller ventricles or hypoplastic ventricles through the bulboventricular foramina, there is communications with the unobstructed pulmonary flow. That is very unusual, because the case mostly we see that both the great vessels are rising from the RV, that's univentricular heart. So this is a exceptional case, very rare case definitely. This particular case, yeah.
Thank you, sir. Thank you, everybody.
Thank you, Dr. Kaustav Kumar Biswas. It was an excellent presentation.